Tech 4, Episode 6. This is your moderator tonight, Dr. Maria Marcy C. Cruz. So before we start, let's ask for God's guidance. So, pa-enlarge naman, Lynn. Lynn, hindi pa naka, ano.
Paper ko, doktora.
Naka-ano pa siya. Hindi pa siya naka-presenter. Naka-slide pa siya. Okay. Dear Almighty, and let's place ourselves in the presence of God. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speaker today of your greatest inspiration so that they may share the most of their knowledge, heart, and soul to their respective topic. May we absorb the invaluable knowledge and put it into practice what we may learn today. We pray that you bless all the committees in charge, that they may be able to fulfill their tasks responsibly, that the objective they have sent may all be achieved. Your infinite blessing would mean the success of this activity. May we be a living witness of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of our Lord and Savior. Amen. Next slide, please. So, good afternoon, everyone.
Philippine Society of Diabetologists. The mission of PSD, the pursuit of excellence in diabetology. The vision of PSD, excellence in diabetology. Objective of PSD, to keep abreast of the most recent developments in all fields of diabetes research, education, and treatment. The PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family, and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing and disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is to support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of effort. Collaboration drives inspiration, motivation, and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
Okay, so tonight we'll run the program. So we have the first part is the Pharma CME grant from AstraZeneca. This is DAPA CKD Revealed, Bringing Renal Protection to Life. Our speaker is none other than Dr. Grace K. De Los Santos. Then this will be followed by Diabetes mellitus type 1 adult management speaker, Dr. Ranais P. Bautista. And this will be followed by our Q&A. So tonight, we want to thank AstraZeneca for this CME grant. Thank you for your support. So our speaker for tonight is none other but our very own Dr. Grace de los Santos, a teacher of mine from the mid up to the present, and a very good mentor. So, hindi ko na siya introduce. He will be introduced by the video. So, can we have it?
Good day, doctors. Welcome to AstraZeneca Philippines Symposium here at the Philippine Society of Diabetologists Special Edition Lectures. This session is supported by AstraZeneca. The session is intended for healthcare professionals for medical educational purposes only. Expert opinions of the participating physicians are based on their experience to date. AstraZeneca does not engage in the promotion of unregistered products or unapproved indications. Please consult local prescribing information for registration product license details. Dapagliflozin is indicated in adults with type 2 diabetes mellitus for the treatment of diabetes as an adjunct to diet and exercise, the prevention of new or worsening heart failure or cardiovascular death, the prevention of new or worsening nephropathy. Dapagliflozin is indicated for the treatment of heart failure with reduced ejection fraction in adults. Dapagliflozin is now approved in the Philippines for the treatment of chronic kidney disease in adults. And to give us a presentation, let's all welcome our speaker for today. She is the immediate past president of Diabetes Philippines Incorporated and the past president of Philippine Society of Diabetologists. She's the head of the education unit and the senior faculty of the Institute for Studies on Diabetes Foundation Incorporated. She is the director of medical education, chief of clinics, and an active consultant at the Metropolitan Medical Center. Ladies and gentlemen, Dr. Grace de los Santos.
Hi, good evening mga kapamilya. Today we're going to talk about type 2 diabetes and how important it is for early detection of the complications of diabetes, okay, and early management of our glycemic control. And we all know that for type 2 diabetes, heart failure and chronic kidney disease are the most common and early complications for type 2 diabetes. And they are the diabetes is an independent risk factor for heart failure regardless of prior myocardial infarction. In fact, 24% of the patients suffering from type 2 diabetes may experience heart failure, and 36% may experience chronic kidney disease. Totaling about 60% of patients with type 2 diabetes may suffer from the so-called cardiorenal disease. And we know for a fact from the different lectures that we have listened before that once the cardiac problem sets in, some of the renal problems that are pre-existing may worsen, or they may start also to have some renal problem, hence the so-called cardiorenal syndrome. And up to 50% of patients with type 2 diabetes will develop heart failure, and that's that bad. And sometimes we don't realize that the patient had heart failure because oftentimes they don't manifest any symptoms of the heart failure. However, during the times when they have problems with acute problems like acute pneumonia, okay, then they may suffer from the symptoms of heart failure. And these are the patients on stage 1 cardiomyopathy, which we have discussed several times in the past. Up to 40%, again, of patients with type 2 diabetes will eventually develop chronic kidney disease. So the data from the Philippines showed that the majority of type 2 diabetic patients of ours had uncontrolled type 2 diabetes, with 60.9% of patients with type 2 having an A1C of more than 7, so that's uncontrolled. And looking at the urinary albumin creatinine ratio of more than 300, about 5.8% of those who registered developed the proteinuria, gross proteinuria. And considering the coexisting cardiovascular risk with very high or high risk, they're about 28.1%. So we can see that in the Philippines, we have a very high numbers of patients suffering from diabetes and having very increased risk for cardiovascular and renal disease. So let's start with our patient who was consulted in June of 2020. So we call her Celia, okay, who is 40 years old, female, who are really newly diagnosed type 2 diabetes with an initial reading of 186, fasting blood sugar of 186 milligrams per deciliter. She was advised medical nutrition therapy. She has a very great family history of diabetes and, of course, kidney disease. And as of now, we all know that kidney disease or kidney complications among type 2 diabetic patients can be genetically determined. Okay, so when we are taking our family history of our patients, make sure we ask them about the existing or the occurrence of kidney disease among the diabetic relatives that they have. Okay, she works as a production line supervisor and works on site 5 days a week. Now, if you look at the results, okay, definitely her sugar is not controlled with 8.5% of your A1C. The target set for her by her physician is less than 7. However, for me personally, she's young, she's newly diagnosed. I will probably set it at a lower level, about 6 to 6.5. And that's my personal opinion. The fasting blood sugar was 158. The target set here was based on the American Diabetic Association target of 80 to 130. For her, probably I'll set it at below 100. Okay. The total cholesterol is also elevated with lower than 100 LDL-C, which is acceptable. However, if you look at the triglycerides level of 244, which is much higher than what is recommended by the American Diabetic Association and also by our mentor, okay, the late Dr. Fernando, he wants it to be below 100, okay, because at the level of 100, your LDL-C, your low density lipoprotein C, cholesterol will already transform into the small dense LDL, which are very atherogenic. The HDL-C for her is acceptable. And looking at her eGFR, she is already suffering from a mild renal dysfunction, and also she is already having microalbuminuria with an UACR of 30 milligrams per gram of creatinine. So looking at her data, she has very high risk factors for cardiovascular and also renal. She already started to have some renal problem. Okay, and we can say that this patient is newly diagnosed. How come she already have the microalbuminuria? Now, there were some studies showing that upon the diagnosis, clinical diagnosis of a patient suffering from type 2 diabetes, a quarter of them already have retinopathy and or nephropathy. So even as we know that these complications are secondary to hyperglycemia, however, because initially all these patients may not be diagnosed early enough, and they may have been hyperglycemic for quite some time before they were diagnosed. So these are the different risk factors that we have to address with Celia. So because of her renal dysfunction, okay, she is classified as mildly decreased eGFR, okay, and also there is the microalbuminuria present. So her risk is with a moderate increased risk for development of your for development of chronic kidney disease, continuously developing kidney disease. And she has to be monitored at least once a year. Now, as the kidney function declines, our patients need to be monitored more often, okay, because kidney function, decline of the kidney function may also point to the occurrence of our cardiovascular diseases. So as she worsens, eventually, if she is not controlled with all the risk factors, including the hyperglycemia, then she might end up with kidney failure, okay, stage 4 or 5 kidney failure, and upon then usually we may have to refer the patient to a good nephrologist who are friendly nephrologists as the kidney disease worsens. Now, from this particular data, okay, looking at patients having exposed to hyperglycemia for a year, for 2 years, 3 years, up to 7 years, they found that the glycemic control is crucial because the dysglycemia or the hyperglycemia increases the risk of the micro and macrovascular complications. Okay, and usually if the first year, if your blood A1C, okay, if your A1C level is above 6.5 during the first year of the diagnosis, usually they are associated with worse outcomes, okay, with worse outcomes. Hence, it is important that immediate intensive treatment for newly diagnosed patients may be necessary to avoid immediate long-term risk of your diabetic complications and mortality. And we know as the patients develop the complications, whether it's microvascular or macrovascular, the quality of life of our patients becomes poorer, and also the expense for the management of the different complications becomes more intensive. So what we need to do is, and there were several studies that when we delay, even just for a period of 6 months delay in achieving the goal that we set for our patients, that these patients have already increased risk for the development of cardiovascular disease and cardiovascular mortality. Okay, however, the trials of intensive glucose control have showed little macrovascular benefit. Now, this has been mentioned several times. The ACCORD study, the ADVANCE study, and the VA, the Veterans study, all showed that with the intensive glucose lowering, it did not show improvement in the microvascular nor the macrovascular complications. However, if you look at the UKPDS, which involve patients who are newly diagnosed with intensive treatment from the very start, then there is improvement when they are followed up for a longer period of time. After 10 years and another 10 years that follow, they have seen that the cardiovascular disease had decreased as well as the cardiovascular mortality. So we have to start early. This ACCORD study, ADVANCE study, and the Veteran study, all these patients that were involved in the study, when they were asked to have intensive control of their diabetes, having an A1C of 6 or 6.5, they were already having like 8 to 10 years of diabetes. Okay, so they had been suffering from diabetes, and as we know, a few hours of dysglycemia will already have some changes on the blood vessels. And these blood vessels, once it started to undergo atherogenesis, then it will continue. Hence, it is important that we really have to start very early if we want to have good results. Now, regarding the study that we mentioned earlier, the 7 years follow-up may not be enough to assess the actual mortality that were related to glycemic control. When you look at the UKPDS, okay, initially after the 10 years, the cardiovascular benefits, the macrovascular benefits was not seen significantly. It was after another year, another 10 years of follow-up, so that means a 20 years follow-up, that they were able to show that there is decrease of the cardiovascular benefit. So, for early prevention of your cardiac as well as your renal complications in diabetes, we have to start strong to attain our goal, and we have to stay strong to control and having our A1C, and all the other risk factors in control, okay, or reaching their goal continuously. Now, just two slides to show, I know all of you know this, that dapagliflozin plus metformin, okay, the zinc duo, actually reduces A1C better than the metformin alone. So the red column is your combination of DAPA and metformin, and the gray column is your treatment from metformin alone. And compare it with the combination of DAPA and metformin compared to a DPP-4, which is your saxagliptin, and your metformin also show that in red, the DAPA fare better than your DPP-4 inhibitor and combination with your metformin. Just two slides just to review, okay? But we know very well that the combination of metformin plus the DAPA or the SGLT2 actually really works better than your DPP-4 and your metformin working together. So let's just go get some review, okay, from the DECLARE study of the CVOT cardiovascular outcome trial of dapagliflozin, which is the largest cardiovascular outcome trial with an SGLT2 inhibitors, okay? And they were trying to look at first the cardiovascular outcome and then secondarily to the renal outcome of patients who were treated with dapagliflozin as against the placebo, okay? And the population has the largest population compared to the other two CVOT of the other two SGLT2 inhibitors, your empagliflozin and your CANVAS program. It involves 17,000 patients, and the population was much different from the empagliflozin, which involved 99.9% of patients already have an established cardiovascular event, while here, okay, we have 40% with established cardiovascular event. The CANVAS program has 40% with some risk factors. Here in the DECLARE study, okay, about 32% had multiple risk factors, but no cardiovascular event yet. So this is for the primary prevention. This is the longest study among the three, okay, having a follow-up of about 5 years, okay, and a median year follow-up of at least 4.2 years, okay, and with the primary outcome again of 3-point MACE of composite of cardiovascular death by MI and also stroke, and the composite outcome also of heart failure, hospitalization for heart failure or cardiovascular death. Okay, but the primary safety outcome is a composite outcome of cardiovascular death, MI, and also stroke. Secondary outcome, they look also at the renal status, okay, looking at whether there will be a sustained 40%, more than 40% decrease in the eGFR, looking also at the albuminuria, whether there's improvement or worsening of their albuminuria. So the pre-specified renal specific outcome is a composite of sustained for more than 40% decrease in the eGFR, okay, and less than 60% and/or end-stage renal disease and/or renal death. And the results shows that there is a 27% risk reduction for the development of heart failure or hospitalization for heart failure. There is a significantly 24% decrease of your development of decreased eGFR, end-stage renal disease, or renal or cardiovascular risk. A significantly 47% reduction in the occurrence of the specific renal specific composite outcome, meaning the patient has a significant, the result shows a significant 24% risk reduction in sustained eGFR decrease of more than 40% and or your renal death or cardiovascular death. and looking at the albuminuria, and we know very well that albuminuria is very much related, okay, with your cardiovascular outcome. Okay. Even in patients without any diabetes, without any kidney problem, if they have albuminuria, usually that will mean that the patients will have more chance of suffering from cardiovascular death, because albuminuria is manifestations of your vascular integrity. Okay, so from the DAPA, from the DECLARE study, in placebo, as far as may or improvement from microalbuminuria to normal albuminuria, from macro to normal or microalbuminuria, and from macro to normal or micro to. So there is improvement in the level of their albuminuria. Okay, how about deterioration? Is there any deterioration? For the patients who were randomized to receiving the placebo, all of them significantly were worsened, okay, worsened renal function. Now, if we look at the EGFR, this has been explained several times in the past, that initially you may see a drop of your EGFR during the initial state, but it doesn't stay long. Usually after 6 or 8 weeks, it will come back, okay? And then at the end of the study, you see that the decline of the curve of your EGFR is less steep than the patients on placebo treated group. Okay, so whether your baseline EGFR is more than 90, 60 to 90, your moderate renal insufficiency, or less than 60, all of them initially did show that there is some decrease, okay, especially here in the first two, from 60 to 90, more than 90 EGFR. You can see that the EGFR initially lower. However, in less than a year, they will be back. And then at the end of the study, even for the other two, okay, at the end of the study, the slope, you look at the slope of the EGFR, it is less steep. And for patients with less than 60, there was no drop. However, you can see that the slope did not drop or decline very steeply. You can see that it stabilized, okay, and a slight decrease or slight lowering, slight decrease of your EGFR, okay, after 2 years of treatment with your dapagliflozin 10 milligrams as against your placebo treatment. However, looking at the safety issues, all of us before were concerned about the acute kidney injury because of the hypovolemia. However, in this particular DECLARE study, it shows that the acute kidney injury did not occur more among patients receiving the DAPA compared to the placebo-treated group, okay? And symptoms of your volume depletion, okay, is not worse than your placebo-treated group. But make sure when we treat our patients with dapagliflozin, we really have to ask them to drink more water, especially when we started them out with somewhat a higher level of their glucose level. Okay, because more glucose, there will be more urine output and they will need more water intake. Okay, more water intake. And as far as the urinary tract infection, again, it did not show more of the urinary tract infection. So urinary tract infections is not actually adverse event for your patients treated with the SGLT2. It is a genital infection. However, my experience with the patients on SGLT2, I had many patients on SGLT2, as long as you initially, when you prescribe them, you ask them to drink more water and then ask them to wash their private part after every urination. Okay, so with that, with good personal hygiene, usually you don't get any of the urinary tract infections or your genital infection. Now, compared to the other two SGLT2 that we have, the cardiovascular outcome trial, as I mentioned earlier, okay, it is the largest, okay, declared. It involves 17,000 patients as compared to the 7,000 of your EMPEREC studies and the 10,000 of your CANVAS program. Okay, and you can see that only about 40% had acute atherosclerotic cardiovascular event already, and only about 60% had multiple risk factors. So we may consider the improvement in the cardio and the renal outcome to be favoring, to be considered to be, or can be treated as for the primary prevention of the complications of kidney and cardiovascular disease, especially the heart failure. And early, remember the registry, that most of the time the echocardiogram of the patients that were having some of the risk factors, okay, and eventually develop heart problem, usually the first manifestation is your left ventricular hypertrophy. So going further, then you may have your heart failure. So DECLARE shows that it can be used for primary prevention of the cardiovascular and the renal complications of our type 2 diabetes, okay, patients. Hence, in 2022, it is more specific now. Okay, from 2017, 2018, 2019, we see that to consider the second drug of choice for patients with diabetes uncontrolled after having them with metformin plus the lifestyle modifications. Later, okay, in 2020, they were the ADA had already recommended that for an A1C that is 1.5 above the set goal, you may start with a dual therapy already, okay? And in 2022, okay, looking at the consideration for the second line of treatment for type 2 diabetes patients, the thing that we look at in the last 3 years is, was there any presence of atherosclerotic cardiovascular disease or indicators of high risk? So the multiple risk factors for the development of cardiovascular disease, or the presence of heart failure, or the presence of chronic kidney disease. In 2022, they were more specific that for patients with established atherosclerotic cardiovascular disease or with high risk for development of cardiovascular disease, we can still consider your GLP-1 receptor agonist or your SGLT2 inhibitors with proven cardiovascular benefit, okay? Because not all of them have the same cardiovascular benefit, okay? Especially the GLP-1 receptor agonist. However, with some patients with heart failure, then what is recommended mostly will be your SGLT2. All of them had their study on heart failure, and it has been shown that it benefited patients with diabetes. Okay, it lowers the hospitalizations for heart failure. However, for patients with CKD, okay, they have more specific now whether they have albuminuria or no albuminuria. For patients with definite albuminuria, then SGLT2 should be considered, okay, to prevent the CKD progression. However, for patients without any albuminuria, okay, and with eGFR of less than 60, so with chronic kidney disease already, that the recommendation is still your SGLT2 inhibitors for the prevention or to decrease your cardiovascular outcome. So SGLT2 is actually recommended for patients with CKD. So in summary, okay, for our first part, CKD is one of the earliest and most important complications. And for SIGA, reduce the risk for hospitalization, okay, for heart failure in patients with or without cardiovascular disease from the DECLARE study. It also reduced the risk of new and worsening nephropathy by 47%. In combination with metformin, it significantly reduced A1C up to 2%. versus your metformin alone. And fewer patients in the DAPA group, in the DECLARE study, than in the placebo group reported a serious adverse event. So more effective, okay, with less adverse event. Okay, so it is indicated for patients with type 2, okay, but now the newer indication is for the treatment of chronic kidney disease in diabetes, and in the KDIGO, okay, recommendations, even for patients without any without diabetes, with chronic kidney failure, with a standard treatment, standard of care, then the SGLT2 inhibitors can be used. At level of lower level of your SGLT, of your EGFR, okay, the sugar lowering effect of your SGLT2 may not be as effective as when your EGFR is above 60. Okay, you expect less, however, you expect the advantage of your improvement of your kidney function, as well as improvement of your heart failure of your patients. So the new indications again is for adults with CKD. So in the Philippines, it's now approved for the treatment of chronic kidney disease among patients, adults, okay, adult patients. So these are some of the, okay, going back to our patient Celia, you will notice that the lipids are not controlled. Okay, he has high level of triglycerides, and the non-HDL, although the LDL is not so bad, less than 100, which is our goal for her. However, when you take the non-HDL, so the total HDL minus your LDL, it is really very high. For patients who have triglycerides, high triglycerides, at times the LDL results may not be accurate. So we'll take the non-HDL component, okay? And usually the one that we want to reach, the goal that we want to reach, you just add 30 to the LDL goal that you memorized from before. So if you want the LDL to be less than 100, then the non-HDL component should be less than 130. So definitely for her non-HDL cholesterol is quite high. So we have to address that. So among our patients with type 2 diabetes, when we try to manage them, we really wanted them to have a holistic management. When they are hypertensive, we treat them with anti-hypertensive drugs, particularly in favor of your ACE, the RAS blockers. Okay, when they have lipids problem, you treat them with, especially when they have cholesterol problem, you treat them with statins. Okay, however, when we try to choose whichever statins that we want to administer or to be given to our patients, we have to consider its effect on the triglycerides and its effect on the HDL. Okay, not just looking at the LDL, you look also at the HDL and the triglycerides, because not all statins are the same as far as lowering of your triglycerides and also raising or lowering of your HDL as well. So we don't want that. We want some statins that can lower the LDL effectively, plus lowering of the triglycerides if needed, and also increasing, okay, the HDL if possible. Okay, and we have to look at the kidney function of our patients. So there were three major, and this was from years ago, that these are the three kinds of patients that will benefit from treatment of dyslipidemias, okay? And in our country, okay, we have our own guidelines for the use of statins in type 2 diabetic patients. So the target for individuals with diabetes in 2020, this is a guidelines from the Philippine, okay, the consensus state or guidelines for the management of dyslipidemias in the Philippines. For patients with diabetes, the target LDL should be less than 100. Okay, however, somebody with diabetes plus more than one risk factors, then the target should be less than 70. However, if there is already established atherosclerotic cardiovascular disease, then the target should be less than 55. Okay, so these are the three groups of patients that we really have to start statin treatment for our patients, okay, especially patients with diabetes. And we all know that a 1% decrease in the LDL will reduce coronary artery disease risk by 1%, and a 1% change in the HDL is associated or increase is associated with a 3% reduction in death or MI. So we have to address all of them. And Crestor or rosuvastatin compared to your atorvastatin had shown that it can lower it can cause greater reduction of the LDL comparing your 10 milligrams as against the 10 milligrams of your rosu and your atorvastatin. And for the 10 to 40 milligrams of atorvastatin compared to your 10 to 40 milligrams of your rosuvastatin, okay, again, rosuvastatin showed a greater reduction of your LDL. And between the 5 and 10 milligrams, okay, of your Crestor, okay, the 5 milligrams can already lower your 5 milligrams is in orange, okay, and the blue is the 10 milligrams that it shows, okay, after the longer you treat the patients with rosuvastatin, then you have a greater reduction or more reduction as you treat them for a longer period of time. Okay, and more people were able to achieve the LDL goals set for them. Okay, comparing your rosuvastatin or Crestor as against your atorvastatin 10 milligrams from the studies. And several studies have shown that the reducing the LDL using your Crestor or rosuvastatin had reduced the 35% of your MI, 30% of your stroke, coronary revascularization by 32%, and coronary artery disease by 26%. And it was consistent. Now, from the patients like Arcelia, okay, who has both problems of diabetes and lipids, dyslipidemias, okay, when we combine the dapagliflozin plus your rosuvastatin, the risk for the development of your end-stage renal disease was reduced by 39%, renal-specific composite outcome by 44%, your cardiovascular specific outcome by 29%, especially the risk for cardiovascular death or heart failure may be reduced by 29%, and the risk for all-cause mortality may be reduced by 31% if you address both the problem of diabetes, dysglycemia with your dapagliflozin metformin combination, and also the dyslipidemia by your rosuvastatin or Crestor. So in summary for the lectures, okay, the priorities for our type 2 diabetes management should always include the prevention of micro and macrovascular complications, okay, alongside with glycemia. So meaning we have to have a holistic management of our patients, including all the risk factors, plus your, not just the glycemia, okay? The risk factors should be included. And international guidelines, okay, recommend, as we all know, I think all of you know already that the first line treatment for somebody for prevention of cardiorenal complications is the use of SGLT2 inhibitors, regardless of your baseline A1C. We have to individualize our A1C target, okay, on top of your metformin use. Sigduo or a combination of your dapagliflozin metformin combination is proven to be effective in the prevention of new or worsening heart failure and nephropathy. Okay, and international and local guidelines recommend the use of moderate intensity statin among type 2 diabetic patients regardless of their cholesterol levels for primary prevention. Okay, so kahit na even if the LDL level is within the goal, okay, set by the guidelines, still they recommend the use of the moderate intensity statins among our type 2 diabetic patients for primary prevention. And rosuvastatin has provided superior LDL-C reduction with more patients achieving goal versus atorvastatin even at the lower dose and significantly reducing your cardiovascular events. One thing is that using of your rosuvastatin should be lowered, okay, particularly, or you can be cautiously, okay, monitor the renal function, especially when you want to use high dose. High dose meaning 20 to 40 milligrams of your rosuvastatin among patients with grade in the severe CKD category. Okay, so meaning they are at level of CKD 4 or 5. Okay, so severe and the end-stage kidney disease status, then you have to be cautious using your rosuvastatin, especially when you're using them at a high dose. You have to reduce the dose. Okay, so as you may have to reduce or you have to adjust the dose of your rosuvastatin if you use them in renal or end-stage kidney disease or in severe kidney status, severe kidney disease status. Okay, and so the final word is when we have our patients, early combination therapy for effective glycemic control and also early treatment of our multiple risk factors, okay, particularly your dyslipidemias and also your blood pressure. We have to take care of that. We have to start strong, okay, achieve our goal early, okay, and stay at goal for all our patients. With that, I would like to thank you for your attention.
Thank you, Dr. Grace De Los Santos, for that insightful lecture.
Thank you very much, Dr. Grace, for that very extensive explanation of patients on diabetes must be on. We have to start it at goal and be strong, stay at goal. So we go now to the second portion of our activity. We have our second speaker, Doctor of Medicine in UST, a fellow training in clinical diabetology in St. Luke's Medical Center, Quezon City. She had MS in IM, major in diabetology in UERMMC, ISDFI, a fellow and diplomate of Philippine College of Physicians, a fellow of Philippine Society of Diabetologists, faculty and treasurer of ISDFI, UERMMC, a secretary of Diabetes Philippines Incorporated, and the chief of clinics in St. Raphael Foundation Medical Center. She's also the head of Diabetes Center and head of Research Training Corps, Our Lady of Mount Carmel Medical Center, Department of Medicine, a consultant and member training corps in Angeles University Foundation Medical Center, Department of Medicine. Without further ado, I'd like to introduce to you Dr. Nice Bautista. So, we will be informed na hindi lahat ng mga may edad ay type 2, no? So, meron tayong bagong knowledge regards to
Good evening,
okay.
colleagues. Good evening, friends from the Philippine Society of Diabetologists. No, first I'd like to thank Dr. Marcy for that very kind introduction, and as usual, a very good lecture again by our very own Dr. Grace De Los Santos. We really learned a lot. So for tonight, my topic will be on type 1 diabetes mellitus update. No, this is I got some slides from 2021 and 2022 American Diabetes Association Convention. First, we'll be discussing the ADA-ESD consensus report, especially in type 1 diabetes in adults. I don't have any disclosure for this lecture, but I got this lecture from the draft of the consensus of the ADA and ESD last 2021. So I have 5 objectives for tonight. First, I'll be reviewing you the flow chart on how a suspected newly diagnosed type 1 diabetes in adult is investigated. We'll be discussing how to manage them, discuss what are the targets, how do we monitor them. We just review a little bit of hypoglycemia and its management in type 1 diabetes. And lastly, the ADA 2022, which I get some excerpt on type 1 diabetes. So this is the first question that I'd like to ask the group. Do you request C-peptide to your patients, adult patients? So maybe your answer is yes. Maybe some of you don't know it, or some of you will say no. Okay, so let us review later what and when will we use C-peptide in our adult patients if we suspect them to have type 1. So as a backgrounder, we all know that type 2 diabetes, there's already a consensus report that has been published, and it has been changed a lot of times. And in recent years, there had been a rapid advances in type 1 diabetes, together with the recognition of the psychosocial burden of living with type 1 diabetes. The guidance for the management of type 1 diabetes, but much is contained within a broader but non-specific. So for this topic, EASD and ADA recognize the need to develop a comparable consensus report specifically addressing type 1 diabetes. So what are the aims and goals of managing type 1 diabetes? Okay, the aim of diabetes care and management is to support people with type 1 diabetes to live a long and healthy life. We all want that to happen to our patient. The management strategies is to achieve this aim broadly, which includes effectively delivering insulin to maintain glucose target as close to normal, to prevent the development and progression of the complication, while we want to minimize hypoglycemia and prevent episodes of diabetic ketoacidosis while treating this appropriately should they occur. We also want to manage the cardiovascular risk factors and minimize the psychosocial burden of people with type 1 diabetes while promoting psychosocial well-being. So, why is the diagnosis of type 1 diabetes very challenging? The first thing that we have to know that the islet autoantibodies that we usually request don't have 100% predictive value. For the past years, we don't know when these islet autoantibodies are to be found. But we have one laboratory that do this islet autoantibody. Okay, but we don't do it often. So C-peptide at diagnosis are relatively high, and obesity and the ensuing type 2 diabetes is becoming more prevalent at a younger age. That is why we have a lot of type 2 diabetes. They are young, okay, and they even have diabetic ketoacidosis, and we might classify them as type 1 diabetes. Only a minority of people with type 1 diabetes presents with DKA, fortunately. And remember that DKA can also occur in type 2 diabetes. We call them the ketosis-prone type 2 diabetic. And we also have to note that there are monogenic forms that can disguise as type 1 diabetes, and type 1 diabetes can even occur in older people, but islet autoantibodies in older people don't equate with type 1 diabetes. These are the different reasons why type 1 diabetes diagnosis is very challenging. So let us look at the incidence and prevalence of type 1 diabetes. It is a major type of diabetes in the youth. It accounts for 85% of all cases in patients less than 20 years of age. The incidence is increasing 2 to 5% worldwide, and the prevalence in the United States is approximately 1 in 300. Type 1 diabetes accounts for 5 to 10% of cases, although the incidence peaks in puberty and early adulthood. Type 1 diabetes affects all age group, which is global. The prevalence is 5.9 per 10,000 population, and the incidence has risen rapidly over the last 50 years and is currently estimated to be 15 per 100,000 per year. So, what is the Philippine data on this? We don't have any prevalence or incidence studies on type 1 diabetes, but a survey done by Castillo Cruz in Bulacan showed only 7 cases of type 1 diabetes among age 0 to 14 during a 10-year period from 1989 to 1998. This is already an old slide. I think we're already in the year 2000, and this had already increased. Okay, so let us now review the flow chart of a suspected type 1 diabetes in adult. So you see an adult patient. You don't know if this patient is type 1 and type 2. So we will be discussing this one by one. So according to the white European population, okay, so this investigation of suspected type 1 in newly diagnosed is based on the data from white European population. So if we suspect an adult to have type 1 diabetes, we should test first the islet autoantibodies. And we should start testing anti-GAD, your glutamic acid carboxylase 65 first. And if negative, this can be followed by the insulin autoantibody 2 and the zinc transporter 8 if they are available. And remember that your ICA antibody measurement are not recommended because of its low specificity and sensitivity when detecting autoantibodies. So once you have checked the autoantibodies, so if the islet autoantibodies are positive, this patient, which is an adult, is classified already as having type 1 diabetes. Okay? And if they are negative, okay, we have to look further. So remember that 5 to 10% of adult onset type 1 diabetes have islet autoantibodies negative. So we have to look at the age. Okay, remember that there's no single clinical features that confirms type 1 diabetes in isolation, and the most discriminative feature that is a younger age at diagnosis, which is 35 years of age. Lower BMI of less than 25. If your patient have unintentional weight loss, ketoacidosis, and blood glucose of more than 360 or 20 millimole per liter, they are very informative. Other features that are associated with type 1 diabetes, such as ketosis without acidosis, if they have osmotic symptoms, family history or history of autoimmune diseases are weak discriminators. So, first, we have to look at the age. Okay, so if the age of the patient is less than 35 years, we have to note that are these patients have features of monogenic diabetes. Okay, we can use the MODI calculator. Okay, www.diabetesgene.org. Okay, this will tell us the probability that these patients have monogenic diabetes. Or you look at clinical features such as an A1C of 7.5 at diagnosis, one parent with diabetes. Remember that monogenic diabetes is an autosomal dominant feature, so it usually runs in the family. And there are features of monogenic cause, such as patients with renal cysts, there's partial lipodystrophy, there's maternally inherited deafness, severe insulin resistance in the absence of obesity. Okay, so with that in mind, these patients can have monogenic diabetes. So if they have those features, okay, we should be testing the C-peptide. Okay, test the C-peptide. So if the C-peptide is more than 200, okay, genetic testing for monogenic diabetes if it's available, should be done. Okay? If the C-peptide is less than 200, okay, this patient has type 1 diabetes. So remember again the age, look at the MODY calculator, look at those autosomal dominant pattern. They have a family history, one parent has it, okay, you look at deafness and everything. So even if they have those, but if you test the C-peptide, it's less than 200, this patient can be classified as type 1. But usually, those patients with those characteristics have monogenic diabetes. So the next question is, if they don't have any features of monogenic diabetes, okay, are there features of type 2 diabetes? If the answer is yes, then this patient has type 2 diabetes. If the answer is no, okay, these patients have type 1 diabetes. So how about if your patient presented, okay, is more than 35 years of age and you suspect that this patient has type 1? There's an unclear classification. You should make clinical decision on how this person should be treated. You should try non-insulin therapy if appropriate. Okay? So, for patients more than 25 years of age, okay, you already tried insulin, tried other agent, then after 3 years, you have diagnosed your patient. Okay? Consider testing for the C-peptide. Okay? So for example, isip mo na type 2 siya. Okay? You give oral medication. Pero parang type 1 siya. Okay? So after 3 years, the blood glucose are getting up and you started insulin in this patient. Okay? Test for C-peptide after 3 years. If the C-peptide is less than 200 picomole per liter, so this patient is type 1. If it's more than 600, okay, this patient is type 2. If it's 200 to 600, okay, it is indeterminate. So again, consider repeating the C-peptide when after more than 5 years. So first is 3 years, then it's 5 years. So a C-peptide is only indicated in people receiving insulin treatment. So if your patient is receiving insulin, then do a C-peptide. If not, then an insulin assay is can also be requested. And a random sample instead of a fasting in a C-peptide, it is within 5 hours of eating can replace a formal stimulation test in the context of classification. So I have used this one. I asked one patient, okay, you eat after 5 years, after 5 hours, test the C-peptide. If the result is 200, okay, the circumstances of testing do not matter. If it's less than 600 and the glucose is less than 4 millimole, okay, the person may have been fasting, consider repeat this testing. And a very low level of 80 picomole, do not, this patient, they don't have to be repeated. Do not test C-peptide within 2 weeks of hyperglycemic emergency. For example, your patient has had DKA, okay, don't test it within 2 weeks. Test it later. So, again, this is the summary of the flow chart, okay, of, although this is in white European population. So, once you have classified type 1 diabetes in adults, okay, how do we manage them? So, when managing type 1 diabetes in adult which are new onset, the treatment depends on the individual preference, capabilities, and circumstances. And our goal is to replace insulin as physiologically as possible, avoiding hypo and hyperglycemia, reaching an A1C target, or if you're using a continuous glucose monitor, okay, then you have to look at the time in range target. So, type 1 diabetes self-management, education, and support is very important. And in there, you should teach them about nutrition, carbohydrate counting, and physical activity. They can be referred to mental health if person request for it. There's difficulty in adjusting to diagnosis. Okay, evidence for depression, eating disorder, high level of diabetes distress, or other psychological issues. So then start glucose monitoring. CGM is preferred. However, all should learn blood glucose monitoring for backup. Okay, you set testing frequency and A1C. You look at them, time in range, time below range targets should be also be discussed to your patient. Then start this patient on insulin. Preferably, a multiple daily dose of insulin is given, okay, which includes pump or hybrid closed loop technology. They can be started based on individual circumstances. Prepare them also for hyperglycemia. You educate them, manage and prevention of hyperglycemia should be discussed. Discuss when how to measure the ketones and provide method for ketone testing. And lastly, prepare them for hypoglycemia. Teach the principle for the prevention and how do you manage hypoglycemia, which I'll discuss later. And if glucagon or your glucagon kit is available, provide it to them, and education on how should it be used should be given. So again, the general principles, okay, in existing type 1 diabetes is adult, the question is, are the glycemic targets met? If not, you have to assess the reasons why. Okay? So discuss option, improving outcomes, and then you can refer them to other diabetes specialists. Okay? So type 1 diabetes self-management, education, and support, principles of nutrition, carbohydrate, counting, and exercise, sick day rules should also be discussed. Okay? And this might be the reason why they're not a target. Consider referring them again if they request it, if they have depression, diabetes distress, and all of these things that I've discussed earlier. So if the glycemic targets are met, okay, continue the management. Just update them on the new approaches to treatment if it's applicable. So then you can offer CGM if they're not using it. Okay, so does this person with diabetes wish to change insulin therapy? If not, okay, continue the current treatment, continue the DSMEs with dose adjustment, and if yes, change therapy based on the circumstances. Okay, intensify insulin therapy if needed. Okay, if on injection therapy and appropriate candidate, you can switch them to pump. Okay, in the Philippines we already have pump. Okay, we have one company that offers this pump. We don't have yet the hybrid closed loop technology. So if we continue on the treatment, there's an ongoing DSME, okay, we can change the current therapy. They can switch back and forth to your MDI, even the pump, okay. Blood glucose should be available to back up the CGM, and all treatment depends again on the patient preferences, capabilities, and circumstances. So in treatment, okay, especially in type 1 or even in type 2, it is usually patient-centered. Okay, we individualize the frequency of visit, okay, based on the need, 1 to 4 times per year, or even more frequent if they're not meeting their goals. If the glycemic goals are stable, maybe every 3 months. Earlier, more frequent appointments can be scheduled if problems arises. And remember, the use of telemedicine, okay, especially in this COVID-19 pandemic, can be given to our patient, and even in-person visit. Okay, referrals can be given, medical care should be given, and self-management education and support. So when we look at our patient, so you have to ask them about the date of diagnosis. Are there any islet autoantibodies that were done? How many DKA? Are there severe hypoglycemia? Hypoglycemia are unawareness? Are there any comorbid condition or complication present? Are these patients pregnant or they're on birth control? You have to review their diet and nutrition, also physical activity, also about smoking and alcohol and even drugs, and even their sleep pattern. So this is our history taking. For physical examination, we have to get the height, the weight, every visit, compute for the BMI, blood pressure and pulse at least once a year. You have to look at the skin site injection, okay? Every visit of skin complaint or erratic glucose reading, otherwise annual, okay? We have some patients that are allergic to insulin or they always inject them on the same site. Look for cardiovascular, okay, annually, fit every visit if with peripheral vascular disease, neuropathy, foot complaints, or history of foot ulcer, otherwise annual. So laboratory, we do this, A1C every 3 months, okay, creatinine annually, urine albumin creatinine ratio annually, lipid panel, this depends on the previous abnormality or treatment. We also check for your ALT and your AST at least once and indicated clinically. Check for serum potassium, especially if they're taking ACE, ARB, or diuretic. TSH, okay, vitamin B12, celiac screen at least once if they're clinically indicated. Okay, you have to look for hypothyroidism or hyperthyroidism, okay, vitamin B12, and even screen them for celiac disease. So again, it's a patient-centered approach. Okay, it is a shared decision making. Behavior really matters: diet, nutrition, physical activity, smoking cessation, and then glycemic control. So for diabetes self-management, this is in section 5 of that draft. Okay, we should provide people with type 1 diabetes the knowledge, skills, and confidence to successfully manage their illness, to reduce acute and long-term complication while maintaining quality of life. We should empower them with an emphasis on shared decision-making and active collaboration with the healthcare team. Okay, we should not be confined to one particular moment, but offered a continuous basis, and it should be tailored to the ever-evolving individual needs. That is why you really have to talk to your patient. So, for the needs assessment, okay, you already look at the health history, okay? You look for diabetes distress, the health literacy and numeracy, because sometimes if they're not that literate, it's very hard to explain it to them. So you really have to go down to deep into their level. You have to look at cultural influences. What are their health beliefs, attitude, okay, especially on herbal drugs, physical limitation, financial status, and barriers. So these are the content of our DSME, the Diabetes Self-Management Education. What is the pathophysiology? How to differentiate it from type 2 diabetes? The healthy eating, which includes carbohydrate counting, the physical activity. Okay, we discuss to them the insulin administration and the insulin carbohydrate ratio, or the insulin sensitivity factor, even correction factor. Okay, the diabetes technology, preventing, detecting, and treating acute complication, preventing and detecting chronic complication, which includes autoimmune condition, help them cope with the psychosocial issues and concern, and even problem solving. So these are the content when we do diabetes self-management education and support. So at diagnosis, all newly diagnosed should have DSME and medical nutrition therapy. Okay, we should ensure emotional health. When complicating factors develop, okay, such as development of complication, the need for steroids, planning for pregnancy or pregnant, then again, we have to talk to them. Annually, or when not meeting their targets, we have to review the skills, psychological, behavioral outcome. Are there any barriers, unexplained hypo or hyperglycemia? And lastly, if there there's transition in life and care occur, such as there is already responsibilities for young adult, okay, living situation changes, and age-related changes affecting diabetes self-management. So on section 9, discuss to them the sick day illness management. There's an individualized sick day plan. Also discuss to them driving, no, hypoglycemia awareness and prevention, employment also, how to safely use and storage insulin. When they travel, okay, create them a plan, okay, insulin doses, the meal planning, the translation of key diabetes terms and requests if they're going to other countries. So additional behavior consideration, these are the things that we should know. So we should assess and monitor the psychological issues if they're present, assess the social determinants of health also. The finance, okay, healthcare delivery and quality, okay, education quality, okay, social determinants and neighborhood also. So next is nutrition. So nutrition, the goals is we want to promote healthy eating patterns, emphasizing on variety of nutrient dense food. This will improve A1C, blood pressure, cholesterol, and they aid in maintaining weight. Again, as discussed last month, it is an individualized nutrition needs. No, this was discussed by Dr. Olive. Practical tools for day-to-day meal planning, and remember that it is focused on matching the insulin dose with meal composition through advanced carbohydrate counting. Okay, we can ask the help of our friendly nutritionists to help our patients on this advanced carbohydrate counting. Usually, when I see patient, no, pagka nahirapan na ako, I usually refer them to Ma'am Jen already. No, especially if they don't have knowledge in nutrition. So if we provide nutrition therapy, no, individualized medical nutrition therapy, okay, which should be provided by a registered dietitian, and this can lower down the A1C by up to 1 to 1.9. And remember that no one eating pattern is recommended for type 1 diabetes. Okay, so it is an individualized approach based on personal preferences, socioeconomic status, cultural background, and comorbidities. Look also at carbohydrate counting, the insulin to carb ratio, and those things. So how about a low carbohydrate and the very low carbohydrate eating patterns? So this is the in thing today. Okay, we have a lot of questions about this. They have been found to reduce A1C in the short term. About intermittent fasting, if this individual wishes to utilize it, okay, then it is important to incorporate it in conjunction with healthy eating guidelines. High fat and high protein may contribute to delayed hyperglycemia, and you should adjust the insulin. Okay, it is very variable if they eat high fat or high protein, and postprandial glucose measurement up to 3 or more hours may be needed to determine the initial dose adjustment if they're consuming high fat or high protein diet. So next is review on insulin management and monitoring. Those are the last two one. Okay, so for monitoring, we use the A1C, which is strong correlation between the average blood glucose on the preceding 3 months. This does not infirm glycemic variability and hypoglycemia. Okay, it's appropriate as the only method for glucose evaluation, unlike your CGM. Okay, many non-glycemic impact this A1C, and this can increase A1C level, the age, ethnicity in African American, if your patient has anemia, iron, vitamin B12, okay, folate, if they have severe hypertriglyceridemia, severe hyperbilirubinemia, chronic alcohol, chronic salicylate consumption, chronic opioid. So your A1C can increase it. Okay, in pregnancy, okay, second and third, there's a decrease. Anemia of chronic disease, okay, such as hemolytic anemia. If your patient has splenomegaly, renal failure, advanced liver disease, vitamin D ingestion, if they're on ribavirin, or apparent increase or decrease depending on the vitamin C ingestion and hemoglobin variants. Okay, so for blood glucose monitoring, it depends on person's lifestyle. It should be frequent. There's an acceptability of high frequency of undetected hyper and hypo, so it should be frequent. Okay, frequent measurement are not often feasible and they're often distressing. Okay, seeing a low or high can evoke frustration and anxiety and guilt. So this may result in less frequent measurement if needed. So sometimes we download them to a memory cable glucose meter and we use the ISO. Okay, so how about continuous glucose monitor? Okay, we can use the real-time CGM and the intermittently scanned CGM. So we have this one already, and the real-time CGM improves A1C and reduces hypoglycemia in patients using pump or multiple injection. And there are randomized control trial that the intermittently scan are more mixed, but observational data are supportive of their use. So most people with type 1 will benefit from this technology. This will, you'll be knowing the glucose trends if they're hyper or hypo, okay, and you should educate them, okay? However, this is not suitable for all. it may not be available or valuable. It may be stressful, okay, or they dislike these things, okay, because they can cause they can be exhausted by the alarm. So CGM is the standard glucose monitoring in type 1. This is the choice of the device should be based on the individual preferences and need as well. So this is an example of ambulatory glucose a profile report. So there are 5 steps, no? We have to look, is it sufficient? Hypoglycemia and assessment, time in range, variability, and stability. So these are the 10 panel or metrics that are useful. Okay, how many days worn? Recommended is 14 days. Percentage that is active, 70%. Look for the mean glucose. Look for the glucose management indicator, and glycemic variability is less than 36%. So time in range, put it at 70 to 180, and then you can time above range, level 1, level 2, time below range, level 1, level 2. Okay, so for type 1 diabetes, glycemic target should be individualized. A1C for most adult is less than 7% without hypoglycemia. Less stringent, less than 8% if with limited life expectancy, just like for type 2. Any reduction in A1C from the high initial level will benefit even if the goal is not yet reached. So for your parameter, okay, for your A1C, less than 7%. Precapillary blood glucose is 80 to 130. Postprandial of 180, 1 to 2 hour. If you're using CGM, time in range of more than 70%. Okay, time below range, less than 4%. Severe hypoglycemia, less than 1%. Time above range should be less than 25%. And glycemic variability, okay, should be less than 36%. So, for type 1, remember more than 70% time in range, okay? For age 25 years of age, if A1C is 7.5, time in range is that target. So, how about insulin? Okay, we are all diabetologists, okay? We know a lot of different type of insulin. The ideal insulin replacement provides near normal state, which allows flexibility. Usually the insulin replacement regimen should be incorporated. The basal insulin restrains gluconeogenesis and ketogenesis in the preprandial state. The mealtime covers for the carbohydrate intake and other macronutrients. And we also use the correction insulin. If they have hyperglycemia, we add a little bit of insulin. They should mimic physiology as close to possible, and this can be achieved using the newer generation insulin, using a multiple daily injection or even a pump therapy. So choice of insulin are your analogs, insulin analog, and the newer basal insulin because they can cause less hypoglycemia. The ultra rapid acting analogs, I think they're already coming, a slightly earlier peak of action, reduce postprandial hyperglycemia, but they're not superior to your rapid acting analog. Despite the cost of these analogs, their costs are barriers for some, especially in the Philippines. But we can still use the regular, the NPH, no? But they can cause higher glucose variability, higher risk of hypoglycemia, less flexibility of their lifestyle, but we can still use them. So how do we administer them? Via pen, via syringe, or even pumps. So again, with insulin replacement, this can be enhanced by putting up a CGM and automation. Remember A1C, time in range, time below range. Okay, some people use the non-regulated do-it-yourself system. So these are the different insulin regimen and how flexible, low risk of hypoglycemia, and the cost. So usually, the multiple daily injection with the long-acting analog, rapid-acting, or ultra-long-acting analog, they're flexible, low risk of hypoglycemia, higher cost. The multiple daily injection with NPH or your rapid-acting or your ultra-rapid-acting insulin, they're flexible also, +2, +2, +2. NPH plus regular insulin, no? +2, +1 for lower risk of hypoglycemia, they have less cost. NPH or even regular or premix, +1, flexible, lower risk of hypoglycemia, and higher cost. For the continuous insulin infusion, no? We don't have to discuss this, okay, because we usually seldom use this. So adverse events of insulin is hypoglycemia, skin reaction to subcutaneous injection, local inflammation. There's an insulin-induced atrophy, even hypertrophy. So hypoglycemia, okay? Alert level 1, if the blood glucose is less than 70, if it's less than 54, that's serious, clinical important. If severe, okay, they need someone to help them. So hypoglycemia can be divided into symptomatic, asymptomatic, and probably symptomatic. So in the SAGE study, this is the global observation analysis in type 1 diabetes. Okay, you can see 3,858 globally in the SAGE studies. You can see here that patients with 26 to 44 years old, okay, uh, proportion with symptomatic hypoglycemia less than 54, 51.8. Okay, if they get older, 45 to 64, 48.6, more than 65, 47, overall 49.9%. So proportion of patients having severe hypoglycemia is also high in this SAGE study. That is why a continuous glucose monitor will really help us in this kind of patient. So what are the factors that contribute to the occurrence of hypoglycemia? Long duration of diabetes, older age, history of severe hypoglycemia, alcohol, physical exercise, lower education level, okay, lower household income, chronic kidney disease, impaired awareness of hypoglycemia, and even hypoglycemia-associated autonomic failure. So, the impaired awareness of hypoglycemia, okay, it is estimated at 25% of persons with type 2, okay. This can be promoted by the loss of your sympathorenal adrenal reaction, okay. We have discussed this in our module before last year. Recurrent hypoglycemia, it can be promoted, sleep disturbances, psychological stress, and alcohol, okay. Glucose level associated with symptoms, we can use the GORD or Clark score or even the Pedersen Bigigard or hypo questionnaire. Then we should be taking action. Educate them about insulin adjustment and even the revision of your glucose target if they have hypoglycemia. So dahan-dahan, huwag nating biglang ibaba. Okay? So the treatment, it's still the rule of 15 gram of sugar. Okay, repeat at 15 minutes. If it's more than 70, further 20 gram if you're using a long-acting carbohydrate if distant for mealtime, kung matagal. So if they have neuroglycopenic symptoms, you usually give your glucagon or even your IV glucose. So those were some of the things that I got from the ADASD consensus. Now on ADA 22. So I just got some. So this will just be quick. So we should know the stages. Okay, we have stage 1. Okay, normal blood glucose. Okay, stage 2, they have abnormal blood glucose already with 2 antibodies. Stage 1 also already with 2 antibodies. Stage 3 with clinical diagnosis already. Stage 4, these are your established type 1 diabetes. Okay, so 5-year risk of clinical diagnosis for type 1 at stage 1 is 44%. Stage 2, 75%. Not available for stage 3 and stage 4. So remember that type 1 is a genetic problem. You have to look at the genetic risk of your patient. There is a triggering event that can produce immune activation. And 5% of all people with diabetes, okay, are type 1. There's insulin deficiency treated with insulin, usually children and young people. So these are the defining characteristics of the different stages, no? Initially, the beta cell mass is at 100%, but at stage 3, it's already at 10 to 20%. So for a different study, you can do primary prevention, secondary prevention, and even tertiary prevention. And these are the different trials for the different prevention studies. So again, this is the natural history. They have a genetic risk. 9 out of 10 do not have a family member with type 1. 10 to 15 times risk in if they have type 1 diabetes. And then you have to stage them, type 1, type 2, stage 2, and stage 3. So biomarker if they have 2 or more antibodies, most likely these patients will progress to type 1 diabetes. So these are the sensitivity of the different autoantibody. Okay, GADA, 99% specific, sensitive in 78%. Insulin autoantibody, 99%, 48% sensitivity. Your insulin autoantibody 2A, 99% sensitive, sensitivity in 72%. The highest is your zinc transporter 8, okay, sensitivity at 78% and specificity in 100%. So these are the different assay type, okay? This is from the islet autoantibody standardization program. So in the AS result, they screened 29,000 patients, okay, and they have found out that 129 have multiple antibody, 807 and single antibody. Okay, the overall positivity rate is at 2.9. So from this number, 147%, the 10-year risk for clinical diabetes is 70%. For this part, 50%, okay, 35 type 1 diabetes had DKA, 4 type 1 diabetes, no DKA. So clinical type 1 diabetes, 5% DKA. So if your patient on screening has one auto-islet antibody, then plus symptom education, if they are negative, you should screen them at 1 to 3, 4 to 6, 7 to 13. If they have 2 autoantibody and you confirm negative, repeat the screening in a reference laboratory at 1 year. So the next thing that I'll be discussing is how do we follow up? So we usually don't do this. No, it's been done in researches. No, although in European and American, United States, they do this. Okay, they do OGTT in research trial. How do we prepare them for insulin, DKA prevention for home blood glucose, start them on insulin and provide guidance. Okay, so what we want to note is we want to monitor the pre-symptomatic type 1 diabetes. So this can be in research, no, cause of type 1, discover the treatment or delay, inform the public health screening. But in the clinic, we have to identify stage 3 type 1 prior to DKA. Then we estimate the risk of progression to type 1, determine eligibility of early intervention. So how then will we monitor? So kunwari pinatest mo ng autoantibody, may single autoantibody, may double autoantibody, pero okay pa yung sugar. Okay? Nandun ka pa lang sa stage 1. Okay? Ano ang gagawin mo para malaman mo kung nasa stage 2, stage 3 ka, or papunta na ng DKA? First is symptom assessment. You can use your glucose meter, A1C, or a glucose tolerance test, your continuous glucose monitoring, and even your islet autoantibody as tool. So, in the symptom assessment, patients with stage 3 type 1 diabetes prior to DKA. So they have an increase in urination, thirst, lack of energy, change in appetite, weight loss. Okay. So when you look at their, they soak their diaper. Okay. There's getting up to urinate at night. They drink more, unable to keep up with their normal activities. They have poor eating patterns. Okay. They have weight loss or growth spurt. Then this patient can be identified to having diabetic ketoacidosis in the future. How about glucose testing? So, stage 3, prior to DKA, okay, again, you all know about normal, elevated, high blood glucose. So, if less than 5 years of age, okay, or dysglycemic, test 2 hours after the largest meal times 5 days, then once weekly if blood glucose is normal. If they are 5 to 18 years of age, test 2 hours after the largest meal once weekly. If they are more than 18 years of age, test 2 hours after the largest meal once monthly, and daily if they are ill or having symptoms. So remember, these patients are already on stage 3. You just want to know if they will progress to diabetic ketoacidosis, or they're from stage 1 to stage 2. So when looking at your glucometer, evidence for this estimate progression is that glucose level increased gradually from 30 to 6 months before diagnosis, and it accelerates 6 to 12 months at diagnosis. Evidence against the glucose meter for estimating risk is that 20 milligram per deciliter in random glucose only marginally predicted increased risk of stage 3 type 1. So 20 milligram increase. Okay, that will tell us that patients might go into stage 3 type 1 diabetes. How about your continuous glucose monitor? Okay, if your patients have autoantibody and more than 10% of the time, if they have 140, there's an 80% progression to in 1 year to type 1 diabetes. So how about oral glucose tolerance test? Okay, 0, 30, 60, 90, and 120 minutes. Okay, this can identify stage 3 type 2 prior to DKA. You can use the C-peptide and metabolic risk score to identify progression to stage 1 and 2. Okay, so if they are less than 18 years of age or they're dysglycemic, okay, you can use OGTT every 6 months, or if they're more than 18 years of age, every 12 months. Okay, if you see that there's an increase and compare it with your C-peptide, then these patients have a tendency to have diabetic ketoacidosis. So this is your C-peptide. There's a decrease in the 30 to 0 minute C-peptide, which is present at 2 years prior to diagnosis. So this is baseline, and then years from diagnosis. So at 2 years, those progressors will most likely to have a reduction in their C-peptide level. So also the area under the curve and the peak C-peptide starts to decline 6 months. So dito 6 months at diagnosis, pababa na siya, and then at diagnosis, sobrang baba na ng ating C-peptide. Remember, C-peptide is co-secreted with insulin. So bumababa na yung C-peptide. So your A1C, again, okay, if they're less than 5 years old, check them every 3 months, 5 to 18 years, every 6 months, more than 18 years, every 12 months. Remember, these patients can identify stage 3 prior to DKA, okay? And also the progression to stage 1. Remember, this is stage 1, meron siyang autoantibody, normal. Stage 2, may autoantibody, pre-diabetic. Stage 3, ito na yung clinical diabetes. And then, stage 4, yun na yung mga nagdi-DKA. So, A1C prediction. So, for every 4%, 0.4% increase in A1C, there's a 5 times risk from progression to stage 3 type 1 diabetes in the DAISY study. So, again, I already discussed about this one. So, to summarize, okay, all of my talk on the ADA 2022, a positive screening test should confirm and promote clinical evaluation to rule out type 1 diabetes with symptom assessment, A1C, and blood glucose measurement. Symptom assessment and home glucose monitoring are essential monitoring tools. Estimating progression or ensuring eligibility for early treatment through a clinical research, A1C, OGTT, and glucose monitor may be of added value. Recommendation for diagnosing and monitoring for in the early stages of type 1, it will evolve over time as more evidence become available. But now, there are less evidence. So, why is it important? Okay, early diagnosis because it is associated with less symptoms, less DKA, and with preserved C-peptide. If you preserve C-peptide with intensive therapy, okay, low risk of hypoglycemia and long-term complication. DKA at diagnosis is seen to predict persistently elevated A1C. So kung di siya nag-DKA, most likely sila tataas ng A1C. And poor long-term glycemic control is independent of other factors. Younger age, higher BMI, weight, Z-score, and higher A1C at 3 months is associated with higher rate of C-peptide decline over the first 2 years after the diagnosis. So, recommendation for our practice, okay, when asked about screening for type 1, okay, so if there's an available screening tool, genetic, okay, autoantibody, glucose level, symptoms. The overall risk of type 1 is greater with a relative with type 1. okay? Especially if they have more than 2 autoantibody. Screening, although we are not included here because these countries have a lot of type 1. The risk and benefit of screening, okay? There may be anxiety in the risk, but the latter, we should reassure them that a negative test, avoidance of DKA, and assess clinical studies to delay or prevent type 1 diabetes. So, information with assurance of privacy and testing antibodies and ongoing monitoring or enrollment is available. No? So, and third is the optimal time for cross-sectional screening in age 2 and 5 years, but screening school age at a lab may be the most practical. Follow-up positive test is needed to reduce DKA. We should discuss them, the results, okay, the implication, signs and symptoms, standard for metabolic control, okay, and then maybe the TrialNet and Inodia clinical studies will be available in the future. So with that, I'd like to thank all of you. To summarize my talk, I have discussed to you ADA ASD recommendation, that's the draft on type 1 diabetes in adult, and the ADA 2022. So how will we screen or monitor those patients who will progress to stage 1, stage 2, stage 3 if they have positive autoantibodies? But remember, okay, we usually don't monitor autoantibodies in our patients here in the Philippines. And because it's very expensive and we don't have the genetic marker. Okay, we only have the autoantibody. With that, thank you for your kind attention. I'll be open for questions.
Thank you. Thank you very much, Dr. Nice, for that very extensive discussion about type 1 diabetes, diagnosis, management, as well as monitoring of patients on how we could prevent or predict patients who will go into DKA. So we have a lot of questions in our chat box. Nice, are you now ready?
Yes, Doctora, I'm ready for any question. Go,
Oh.
fire.
Fire. So
Teach ko lang
they're
ilaw.
very curious if Dr. Elvin is very curious as well as Dr. Grace if the new management for diet is there a study where in type 1 diet they use SGLT2 for type 1
I think we
or
don't have any
DPP4
study.
inhibitor?
For SGLT2 first, I think there are no studies using. There are studies for type 1. Remember the one that namuta ko yung SGLT2, the one that Sanofi, their SGLT2 inhibitor, they made some studies but in type 1, but it was not approved. They in the use in patients with type 1 diabetes, even if they're adult because of the risk of DKA. Last year, we also discussed about glucagon as a mechanism for type 1 diabetes. And there are studies using DPP4 inhibitor, but remember, these are small studies. Insulin is still the primary treatment for type 1 diabetes. So we have reviewed last year about glucagon that it's not only insulin that's a problem in producing diabetes type 1. So it's the problem in glucagon. But there are small studies, but insulin is still the mainstay treatment.
How about from Dr. Grace, the use of pramlintide
Lentide.
from lintide?
I think last year we also discussed that pramlintide, an amylin analog that can reduce postprandial blood glucose in diabetes.
Mm-hmm.
Yeah.
So another question from Dr. Glenn. Sabi niya, is LADA the same with type 1?
Okay, I think LADA is latent autoimmune diabetes. Okay, so they have the phenotypic type of the type 2 diabetes, but in the future they have development of autoantibodies. They are different from type 1 diabetes, wherein the pathophysiology of type 1 diabetes, it's a genetic preponderance, meaning they have problem with their human leukocyte antigen, then there will be a trigger, then autoantibodies will be increased. But in LADA, they have the features of type 2, so it's a slowly progressing disease that will develop autoantibodies when you check on them, maybe after 5 years.
Okay. So, again, nice in a Philippine setting, ano? Philippine setting na to, ha. So, what would you advise us to do for diagnosing adult type 1?
Okay.
For Philippine setting wherein we could not find any genetic studies around.
Remember the guideline that I discussed were from the European network, okay? Because it's really for them because they have a higher incidence of diabetes and they have genetic studies and they do multiple autoantibody. But in the Philippine setting, okay, just like what Ada tells us, that if your patient is age less than 35, especially if they're young, less than 10 years of age, developing DKA or they have hyperglycemia, and then this patient might have type 1. But we have already some autoantibody that we can request at I think in high precision. I usually request that now because nalaman ko na it's present. So sometimes kasi nangungulit yung pasyente, ano ba ako, doc? Type 1 ba ako, type 2? So I offer that. Okay?
So ano ba yung ngayon sa available sa high precision?
Alam ko yung ICA at saka IA2. Parang yun yung available.
Ano yan?
Request
For
ko
the,
sa
for the ano, for
mga
the
may
knowledge
insurance
of,
mga
may
bata.
insurance.
May mga HMO sinasagot nila. And then sa mga ano rin, I also request for C-peptide. And it's very important to note that C-peptide is really increased, no? Within 2 weeks of hyperglycemia. Kaya, so dapat we really have to wait. And then if they are adults, so you have to wait for 3 years and then to measure the C-peptide. Kahit na random stimulation, that is, we just measure the fasting C-peptide, fasting insulin. So pwede na pala yung the 5-hour random test with C-peptide can be used as a marker with your C-peptide for type 1 diabetes.
Again,
Yes,
another question. Yes, ma'am.
Yeah, nice lecture. Comprehensive lecture. Congrats. Ang gusto ko lang malaman, nice, is if you measure the C-peptide, do you measure, like you said, it's after 5 hours or the fasting that we used to know na yun ang kailangan? You have to coincide with the measurement of
Random
sugar
blood
also,
sugar.
glucose.
Yes, ma'am. Sinasabay ko RBS and C-peptide.
Tama pa ba yung alam ko?
Stimulate.
Kita.
Ma'am?
Tama pa ba ang alam ko? Na if you measure your C-peptide when your blood sugar is very high, that the result will not be accurate kasi physiologically, if our blood sugar is high, ang ating beta cells is not very responsive to the glucose generating the insulin release. Tama pa ba ako?
Yes, ma'am. Tama po.
Iba na ngayon. Tama pa rin?
Ganun pa rin, ma'am. Kaya nga, C-peptide, hindi din natin talaga siya ginagamit much during the early disease. Better, yun nga, ang guideline, although again, this is European, at 3 years and 5 years. Maybe we can do some studies on this, no? Tinitingnan ko nga kaya nga yung mga type 2 ko na tinitreat, na tapos biglang ang tataas ng dose ng insulin, baka naman mga type 1, kaya pinapa-C-peptide ko, maybe in the future, makakollect ako ng maraming data and with you, we can request, baka makagawa tayo ng paper on this one.
Pero dapat ang C-peptide, i-measure mo na naka-insulin yung pasyente na medyo,
yes, ma'am,
medyo mababa, right?
Mababa na yung, yes, ma'am, you're right. Huwag yung insulin assay kasi kung naka-insulin, taas, so it's really C-peptide.
At saka 5 hours.
Oo, ma'am, yun yung recommendation, 5-hour stimulation.
So 5 exams or?
Hindi, isang beses lang.
At
5
the
hours.
after eating?
5 hours after eating, check on it.
Any particular grams of carbohydrates or
Walang
Hindi siya
sinabing
glucose tolerance test.
wala man,
Wala,
basta
basta
random,
postprandial
oo.
lang.
5 hours. Maybe it mimics yung tinignan siguro yung area under the curve na pagka mababa talaga, type 1 talaga yon. Remember
Pero
the number less than 200 picomole.
Pero, guys, hindi ba minsan, yung depende sa pagkain natin, yung emptying, stomach emptying time natin, saka yung pagpasok ng mga nutrients sa ating dugo, hindi ba it varies with the kind of food that you're taking? Pag fatty, medyo mabagal. Pag protein, medyo mabagal. Yung ganun, di ba?
Yes, I agree with you, ma'am. Kaya lang baka yung kanila yung C-peptide maybe it's not affected siguro by those. I just presume it. But I really don't know the answer. Maybe next time I'll talk to you. Mas magaling ka, ma'am, sa physiology kaysa sa akin.
Hindi naman. Kasi kapag nakikinig sa'yo, sabi ko, parang marami na akong walang alam.
Dahil ma'am doon sa bagong mga hours.
Oh,
Ay, nice. Alam mo ba yung presyo ng mga antibodies?
Oo nga eh. Gusto ko
Super mahal. Nagtanong na ako kasi I have one patient na talagang hindi ko ma-type 1 or whatever. Alam mo kung magkano nagtanong ako?
parang 10.
18,000.
Oh, alam ko, ma'am, ganun nga eh.
18,000 ang isang test, ha? Isang test lang na antibody. E
Oo,
then
ma'am,
yung
alam
test
ko.
for 2. Si Ray, madalas nag-order.
Oh, si
Ray
Ray.
Rosales, si Ray, pwede natin tanongin.
18,000.
Kaya nga, ako ba si Ray Ray? Ano yung
Sobrang mahal.
mahal pala?
Grabe.
Isa na lang.
Grabe pala, no? Okay. So with that, tayo ay inabot na ng 8 o'clock. So we have to end up our answers and questions. We have a very interesting night and something new, no? Hindi naman lahat alam ito, no? So something new to us. So with that, I say thank you very much for the two wonderful speaker, Dr. Grace de los Santos as well as Dr. Nice Bautista. So we have to end the night. I hope everybody is
Pa-open lang po ng camera for picture po.
yeah. Can you open all your cameras para sa ating documentation for picture?
Okay
So
po. Pa-open na lang po.
before we end, we thank you we thank you AstraZeneca for the continuous support with PSD Select. Thank you so much, Astra.
Okay po. 1, 2, 3. Smile lang po. Wait lang po. Isa pa po. Okay po. 1, 2, 3. Thank you po.
Okay na?
Thank
Then till we meet again on August 27, yeah, at 6 p.m. So we have our topic, the gestational diabetes by Dr. Lailani Valdiviso, and as well as the obstetrician Maria Lourdes Escobar. So see you then. I hope everybody is fine at mag-ingat pa rin tayo sa COVID. Talagang tumataas yung case and we have the first case of sabi nga monkeypox. Okay, bye-bye everyone. Thank you so much.
Thank you, doctors. Thank you,
Una na tayo. Thank you very much.
Thank you, Sir Kim, Sir Miggy, Sir Ma'am Bidi. Good. Thank you po, Sir Noel. Thank you.
Thank you. Thank you, everyone. Danny, hello. Nandiyan ka pala.
Oo, kanina pa ako nakikinig. Galing. Thank you.
Welcome.
Si, si Dr. Ang, lecture siya dapat sa ISD con. Hindi na siya.
Dr. Marcy,
Register na po
nakamute
kayo
po kayo.
lahat. Mag-register na po kayo sa ISD convention. Kailan ang
Sabi
tasting
nga
nyo, ate?
ni Ernie, nagre-retire na raw siya.
Chika lang yun.
Oo
Kailan
nga,
ang food tasting nyo?
wala pa kaming pinag-uusapan, pero
Lynn, samahan mo na si Doktora. Magpa-testing na kayo.
Okay,
Po, Doktora. Sabihan niyo lang po
Okay.
kailan.
Para maaga.
okay.
Thank you po, Doc. Congratulations.
Thank you very much.
Thank you po.
Bye-bye.
Doktora, okay po. Thank you.
Hey, Lynn.
Yes, Doc.
Lynn, sinong dumating
Yes,
na
Doc.
board?
Bali, wala po si Dr. Fatma and Dr. Rocky and Dr. Jamie.
Bakit daw?
Si Dr. Jamie po, kasama daw po niya sila Dr. Ambe. Kaano niya?
Nasa ano sila? Pad. Sino pa?
Yung dalawa
Sino
po
si
walang
Dr.
ano,
Fatma? Ha?
wala pong reply.
Si Doc Rocky?
Wala pong reply.
Ay, may birthday pala. May ano siya. Mayroong birthday ng kapatid niya.
Hindi po nag-ano Doc.
Birthday ng kapatid niya kaya hindi siya nakapunta.
Oo nga, nakakatakot siyang birthday, no?
Oo nga. Siya pa naman. Sila pa naman.
Oo, okay.
Dito nga sa tabi namin may kasal-kasal pa sa sa mga hotel.
Oo
Nandito
nga.
ako sa PCP.
May naging ano yata, medyo nagkaroon ng restriction ngayong month na to. Yung hotel, nag-announce sila na yung
Baka
capacity
80% na lang ulit binawas.
50% ngayon.
Ha? 50 ulit?
50%, kaya nga daw
Ay,
nag-back
Lynn,
out.
pakicheck mo nga yung Shangri-La.
Pero for this month, sabi
Ngayon,
nila, hindi pa nila yung
Hindi pa alam.
months.
Magbabago pa ulit. Oo nga.
Dahil lang sa tumataas yung kaso.
Oo.
So, everything
Mataas naman yung number pero wala namang masyadong mortality. Kaya siguro okay.
pero sabi ni Ma'am Gracian, merong 'di ba, ejection fraction na 50 lang. Because of
Baka hindi naman lahat.
Oo nga. Hindi, kaya lang nakakatakot pa rin kahit
Oo,
mild.
baka matapat sila.
Sige,
thank you.
Okay,
po.
bye-bye.
End ko na, Doc. Okay po, thank
Sige na.
you.
Bye-bye.